Hello, Papper people. Hey all, thanks for coming back. I'm the Lanky Lefty 27, otherwise known as Grandpa Lanky because I'm old and fat. I'm a registered polysomnographic technologist, and I'm a thick one at that. Thick. I also suffer with obstructive sleep apnea myself, and I use a CPAP. I worked in the field for like 25 years, and this question has titillated me to no extent. Thanks for all that you do and your videos, Jason. This is somewhat related to this video and your exploration of non-responders / outliers to CPAP bilevel treatment. Why do you think there isn't a better diagnosis or diagnostic framework for sleep apnea? As you are aware, most people are diagnosed with OSA and just given a CPAP. Better CPAP support and education would be a huge win, but can't we go further? Why is there an obstruction? Is it positional? Is it due to tongue posture? Is there upper airway restriction? Is there lower airway restriction? Is there a nasal restrictions? Adenoids, septum. I'm going to actually add turbinates. Is it a weight issue? Muscle, adipose of the chest, throat. Is it a central issue? Airway size, volume could be measured by cone beam computed tomography scans, which are quick and relatively cheap. Perhaps go to a sleep endoscopy for stubborn, more complex cases. All of the potential causes seem to have specific solutions, and it seems like with a good sleep study and a CBCT scan, we could have much more targeted treatments. CPAP, bilevel, ASV, or Inspire for true central apneas. I need to correct that. It would be for obstructive events. It would be CPAP, bilevel, Inspire. ASV and Remedy would be for central apneas. I digress. CPAP bilevel for weight issue, pressure to support airway, pair with lifestyle interventions, MARPE or other palatal expander for upper airway restrictions, septal deviation correction for nasal restrictions, consider maxillomandibular advancement surgery for lower airway restrictions or combined upper-lower restrictions, myofunctional therapy, and positioning techniques when relevant. I'm not pro-surgery or invasive interventions by any means, but I wonder how many people fail CPAP / bilevel simply because the device is just forcing more air into too small of a passageway, like trying to increase flow from a narrow diameter hose or simply upping the water pressure. It'll work, kind of, but getting a bigger hose is probably the more efficient strategy. I've been on a 10-year journey attempting to treat OSA, CPAP, bilevel, countless mass and setting changes, mandibular advancement devices, septal deviation surgery, myofunctional therapy, specific sleep positions. Only now, a decade in, did a provider suggest a CBCT scan revealing narrowed upper airways, specifically low volume nasal cavities and a transverse maxillary deficiency, narrow, and retruded maxilla, leading to a low volume retropalatal space. I could mess around with CPAP bilevel forever and not resolve these. Am I oversimplifying things? Why is there not a better diagnostic and treatment framework, do you think? Now I'm going to skip ahead a little bit. This is not an indictment of you or your work in any way, just of the system in general. Man, the system is jacked. I will tell you that. Let me first get this out of the way. This is actually going to tie in, so just trust me. So the sponsor of this video, this is going to sound bad, is cpapsupplies.com. Now, bear with me because this, I promise, is going to tie into the video. cpapsupplies.com, any mask or accessory you want, you can use a fresh discount code that is Lanky Winter. Lanky Winter saves you 25% off. You also get 100 loyalty reward program points. In addition to that, they have all these wonderful things, these free prescription services, free shipping on all orders, 30-day mask guarantee, loyalty reward program, and a 30-day price guarantee. What's there to lose? CPAPsupplies.com is a fantastic partner for me personally because they really don't care if I go off script and wacky like I'm going to do right here. So I do have a couple of points I want to mention, but in short, if we're going to keep this super short and you're like, my attention span's like a minute and a half and you're already testing that, Jason. If we look at this, all the potential causes seem to have a specific solutions. It seems like with a good sleep study and a scan, we can have much more targeted treatments. Deviated septum is a physical obstruction. It's not going to move. Turbinates that are enlarged and inflamed, it's like when you breathe in your nose, it's what like swirls around, cleans them, warms them up before it goes into your lungs. When those are inflamed, they're not going to move at all. So if you have a septoplasty or a turbinate reduction or adenoid removal, that's going to create space. Tonsils, same thing. That's going to create space of something that basically isn't going to move otherwise. So with the hose analogy that they use, which I love the hose analogy, if you get rid of those physical obstructions that no amount of pressure is really going to do anything about, all you're left with is an obstruction somewhere. Doesn't really matter where it is. If you look at, it's like taking an aspirin. You can take an aspirin and it's your toe that hurts. And then you can take an aspirin the next day because you have a headache. You can take an aspirin the next day because you have a backache. It doesn't know where the obstruction is. It just works on the entire body. And I see PAP therapy is working the exact same way. That's why I'm really big on CPAP, bilevel, ASV. It doesn't know where the obstruction is. It doesn't care. It just inflates the airway so that you can breathe and stay asleep, hopefully waking up happy. Now, that is super simplifying it. So let's do this. The question specifically, why is there not a better diagnostic and treatment framework, do you think? I think it comes down to time and money. Simply put, that's it. It's time and money. How do I think that we could simply, like very simply improve things like day one, like right now? Let's implement these things and let's make it better. And I'm so interested to hear what any of you boobs have to say about this in the comment section. What is your approach to this? Number one, I think it's got to be education. And then I'm not talking of us as patients. I'm talking about the doctors. I'm talking about the frontline people, the home, like the family practice doctors, the family practice, the FNPs, the PAs. Anyone who sees the masses needs to know something about sleep disordered breathing. Now you also have to add in the sleep docs, the people who are specialists in sleep. We still have some that are denying upper airway resistance syndrome is even a thing. That's freaking bonkers to me. Dr. Christian Guilleminault, God rest his soul. I've mocked him on videos and now he's passed away and I feel bad about it. He devoted his life to, at Stanford, researching upper airway resistance syndrome. And now you have sleep docs who are like denying it exists. That's freaking bizarre to me. Recently, I was doing a PAP therapy analysis with someone and they said that their sleep doctor said, no, upper airway resistance only happens in children. No, it was first described in children before then being expanded to adults. Hey, adults actually have this too, and it's its own unique diagnosis. Okay, that's all on a side. So education for, I'm just going to say, physicians on this stuff. It needs to be updated. There needs to be more time spent on it. And if not, like everyone, for the love of God, please sleep specialists for sure. Now, as far as the sleep studies per se, that's a tough one. I think part of that is just our whole healthcare system in general. I'm not a fan of it. I hope this doesn't get political. God knows I got in trouble using George Clooney, of all people, as an example. Somehow he's the worst person ever. Did anyone know that? George Clooney is the worst ever? No idea. Our healthcare system, I really just don't like. It's you have these insurance companies that basically tell you what to do. They tell you how you can get tested. They tell you what treatment options you have, and you have to jump through all the hoops. Self-pay option, you can choose to come to me or you can choose to not. You can choose to have a home sleep study with me or you can choose to not. There's some doctors that will refer to me that have their own self-pay model. They're set up slightly different, but in essence, they don't accept insurance. Cuts down on a lot of the busy paperwork overhead so that the prices can really come down. And you can say that, hey, that's concierge medicine, that's expensive. I disagree. I think it's actually a lot cheaper. If you see some of these doctors' prices, there's some in Tennessee, there's some in Texas, there's some in New York that I've worked with, some in California. The prices are actually pretty low. So that's part of the problem with diagnostics. But overall, I don't know that diagnostics is a huge problem. The one thing that I think this guy touches on that would be really great is to involve the ENT a whole lot more. Otolaryngologist, I believe is how you say it. Ear, nose, and throat doc. If you could have people scoped, you can see specifically where the obstruction is. You can check out, is it deviated septum? Is that a problem? Turbinates. Do they need a turbinate reduction? Those kind of things. If those are addressed, CPAP, bilevel, ASV all work so much better. That leads me to the machines. So 1, better education for physicians. 2, involve the ENT a whole lot more in care. include the CBCT scan. Those would be great. 3, the machine that is used. Why is it we have these machines that literally look the exact same, have the same machinery in them, but the firmware is different, and the firmware is what changes how the machine reacts and can behave? We have people, or I have had people, 5 people to be exact, that have taken their AirSense 10 auto CPAP, they jailbreak it, they add firmware to it, and now this machine that was only capable of CPAP is now capable of CPAP, bilevel, bilevel ST, AVAPs or IVAPs, ASV. It can do everything because they added some firmware to it. Patients need to be given a machine that is literally capable of everything because you don't really know what they're going to need. And things change. There's been people I've worked with, they were on CPAP forever. Things were working great. And then all of a sudden they have something happens where now they do need ASV. They have developed central apnea. Why do they have to go back to a lab? Just change that baby to ASV. For sure, do a left ventricle ejection fraction. Make sure that they're above 45%. But once you have that, that's okay. Why not just change them to ASV? It makes it simple. Why have to go through the expense and the time of having a sleep study to get put on ASV to satisfy some third-party insurance that's wherever the hell they are? And probably the last piece of this puzzle is having sleep specialists employ a bunch of polysomnographic technologists like myself to use programs such as Oscar, open source CPAP analysis reporter, to look at the data of people, check them for mouth leaks, check them for mask leaks, check them that their mode of therapy is appropriate. You just do this for a short period of time, a very intense, like, hey, we have 2 weeks. We're just going to drill down on this. Boom, you're done. You should be good for several years. Now, again, is this the most efficient thing? No, it's going to cost time. It's going to cost money, but there's certainly a need for it. And if you look at the whole like sleep as a whole, what's crazy about it is you'll notice people say like, hey, when I got on CPAP, my high blood pressure that I wasn't able to control ever, all of a sudden is now controllable. I even got off my medication. I've heard of diabetes, metabolism improving just by having better sleep. This is like, I'm not even talking about the quality of life that you experience, the quality of life improvements. Simply breathing at night and able to go through all of your sleep stages, that alone is worth it. But then you have all these other medical conditions, but whatever, we can go into that forever. So some of the things I did not mention is there is absolutely a place for devices such as a mandibular advancement device. That has helped a lot of people. You have a different form of mandibular advancement device that is called the iNap. I haven't mentioned the iNap in a video in a really long time. iNap actually works really well, in my opinion. So it's a little tube that sticks in. You have like a mouthpiece and it sucks. It pulls air out of your mouth. And then so all the tissue back here is going to pull in to try to fill in that void. And it opens up quite a bit of space in your upper airway here. I feel like that's definitely worth a mention here. So other things that have been mentioned was Inspire. I'm really not positive on Inspire. I want Inspire to work, but the problem I've seen with Inspire is that you have gruesome scars from placing the device, the implant. I've also heard, I thought it was just an outlier, but now I've heard it like 5 times, where when people sneeze, they bite their tongue. And so far, the best person that's been willing to talk to me, actually 2 people have said this, they had Inspire placed, they used it, they stopped using it, they're back to CPAP or bilevel. And I said, well, like, do you hate it? And they're like, nah, I just CPAP, I'm just doing CPAP. It wasn't like they hated it, but they stopped using it. So now they have this device in them that they're not even using. So that's like the best as far as people that would talk to me. Have a lot of people that'll pop on when I do an Inspire video and they say like, oh no, you just hate it because you every reason you can think of. And I'm like, great, could you talk to me about it? Like do an interview. It doesn't even have to be recorded. I just want to talk to you. And they're like, no, you're going to twist my words. If I do a video, I can't twist your words. Did you know you can use my Amazon affiliate link I earn on all qualified purchases? Probably should have done that before Christmas, but here we are. So that's really all I've got for you. I appreciate you guys watching. Let me know what you think about this in the comment section. Check the description box for some helpful links. Check out the sponsor of this video, cpapsupplies.com. If you want to have a PAP therapy analysis with me, one-on-one Zoom session, axgsleepdiagnostics.com. And other than that, why don't you buy some Mass Bright because your mask stinks. Clean your stinky mask with some Mask Bright, available at Amazon. And time for an extra thick thanks, buddy, to my top-level supporters, Doug Toombs, Jason Georgiades, Patricia Espelong, Stuart Hetherington, Alan Liu, Edward Steiner, and I'd like to say thank you also to these people, as well as those other people. Up the ante, you get a shout-out. Thanks for watching. Bye-bye. Barely even on screen, but still appreciate the support.